This is EHJ today at the Annual Congress of the European Society of Cardiology in Rome, Italy. I'm Tom Lucier, Editor-in-Chief of the European Heart Journal, and I'm talking to Peter Nielsen from Aalborg, who presented a large registry at this Congress on patients with intracranial bleeding. And we're talking also to Professor Greg Lipp from Birmingham. Welcome. So Peter, tell us what was the question that you wanted to answer with your study?
The question pertains to AF patients who survives an intracranial hemorrhage. And actually the basics from the study goes back to a couple of years ago. We presented a similar observational study based on the Danish registries on ICH survivors, but it was all anticoagulated patients and all free from stroke. Some of them encounters an ICH on warfarin therapy during follow-up. And then we looked at the subsequent ischemic stroke rate, and it was quite high.
So ICH is intracranial hemorrhage, for those who are not familiar with the abbreviation, yes? Good, so that was the question, but you did also look at different patient groups, didn't you?
Exactly. So from this study, we carried on to investigate the prognosis from restarting OAC therapy, oral anticoagulant treatment, post the ICH event. So we know that these patients have a high risk of stroke due to the AF, atrial fibrillation, and we do know that patients benefit from OAC treatment if they have a perceived high risk of stroke, obviously.
But they also have a risk of bleeding, obviously.
Exactly, and what we really fear as clinicians is the recurrence of the intracranial hemorrhage.
Okay, so how big is this Danish cohort?
The AF patients cohort is a large cohort. Obviously, only a few patients encounters in hemorrhagic stroke or an intracranial hemorrhage. Now, the numbers are around, in the study population for this study, around 2,000 patients. Now, the important part is that we only investigated survivors' hospital discharge 14 days after that we commenced observation time. Now, what we did in this study was to stratify between patients who encountered a spontaneous intracranial hemorrhage, hemorrhagic stroke, and a traumatic intracranial hemorrhage. So the cause, whether or not it was known, the bleeding inside the brain.
And the spontaneous bleeding was under anticoagulation, or?
Yes. All on anticoagulation at baseline.
At baseline, yes. And so these patients, how many what was the incidence? What was the overall population, and how many had intracranial hemorrhage in the Danish registry?
As I recall it, from 1998 to 2014, there are about 7,000 to 8,000 patients who encountered an intracranial hemorrhage on warfarin or NOAC therapy.
So that's quite substantial. So it's about 500 per year, huh? So more than one a day. So it's in a country like Denmark, which is not huge. Yes. Yeah. Okay. What did you find then?
We observed whether or not the patients restarted the OAC treatment, and what we could see that patients who encountered a spontaneous intracranial hemorrhage, hemorrhagic stroke, was prone to recurrence of bleeding in a higher degree, but also at a very high degree of encountering an ischemic stroke.
Okay, what do you call a high degree?
High degree was based on an event rate at high risk.
So how many? What was the percentage roughly? I mean, from the initial cohort, how many did then actually restart anticoagulation?
Around 500, which was restarted OAC therapy within the first year.
Yes. And from those, a significant number had again bleeding. Did they?
Yeah, a quite large number encounters a bleeding again.
A bleeding, yeah. And this was higher in the spontaneous group than in the traumatic group, was it?
It was.
Yes. How do you explain that?
I think that Perhaps the spontaneous intracranial hemorrhage was related to perhaps a transformation from an ischemic stroke to a hemorrhagic stroke. Yes. We can't see that from the registries due to the coding.
While the traumatic stroke has a clear-cut cause that may not reoccur. Mm-hmm. Yes, okay.
But what we could see from the baseline characteristics from these patients was that patients with a spontaneous intracranial hemorrhage had a higher degree of prior stroke in comparison with the group with traumatic intracranial bleeds.
So what do you tell practicing physicians from your results? What can they learn from it?
I think it is important to emphasize that these two patients coming in at the hospital with a bleeding inside the brain are not equal, whether or not this is caused by a traumatic, say a fall-related intracranial hemorrhage or a spontaneous event.
So you think that if you fall and you have a bleeding and you can manage the fragility of this patient so that you will avoid falls in the future, you can restart anticoagulation rather than not? And in the other group it's going to be quite risky, is it?
From our data it was quite evident that the patients with a traumatic intracranial hemorrhage, the cause was traumatic. Yeah. We could see that restarting OSC therapy was associated with a lower degree of ischemic stroke, obviously, but also a similar rate of recurrence of intracranial hemorrhage. Yes. And a clear benefit in terms of mortality endpoint.
So Greg, I mean, you're the pope of anticoagulation in stroke. There's always, of course, the sculant cariptis, as they say in Italy, that the bleeding and prevention of stroke, and if it's the same rate, of course, then there's a neutral effect, and hopefully we can select the patients that really benefit. And what did you learn from this registry?
Well, I think these are important data because the first aspect is patients with a previous intracranial hemorrhage are excluded from the randomized trials. So we cannot look to the randomized trials to give us an answer whether or not these patients are going to do well or not from restarting anticoagulant therapy. And indeed, I'm aware of, obviously, with Peter's work before, clearly showing that such patients are very high risk of subsequent ischemic stroke. They are also high risk of death. But when they are restarted on anticoagulant therapy, there's a clear reduction in the risk of subsequent ischemic stroke and mortality, but there was no excess risk of major bleeds. And with recurrent intracranial bleeds, I think this current work extends the field, because if you're looking at spontaneous intracranial hemorrhage, I don't think that's homogeneous, because the deep lobar versus the cortical, and the Danish registries do not have that granularity in terms of the cerebral imaging. I think those who are having the deep cortical are particularly high risk. There's a lot of interest in cerebral microbleeds, and it's no doubt some of those patients showing the increase in recurrent bleeds that Peter just highlighted, maybe accounting for that after restarting on anticoagulant treatment. But the other message is also important: the traumatic intracranial hemorrhage. There was no excess harm, and that's in the guidelines and recommendations. The history of falls itself is not an independent predictor of bleeding on oral anticoagulant therapy, because again, sometimes it's a mechanical fall, and these things you can't avoid, and physicians, when the take-home message is to make sure that they don't withhold anticoagulant therapy because a patient's perceived to be at risk of falls. In fact, they're probably doing harm or malpractice by not treating these high-risk patients.
Right. So, one possibility that we are increasingly using in our department is the left atrial appendix occluders in these patients. Did they also have occluders in your registry, or you didn't look at this at this point?
We didn't look at it at this point, but obviously these extremely high-risk patients, as Greg mentioned, the deep lobar, are of course candidates for this type of treatment.
What do you think about this as an alternative in this particular group?
I think that certainly is an alternative. That I think there are certainly more data to come, and what we'll have over the next year or so is a large number of studies reporting. In the UK, we have the CHROMIS-2 cohort, which is the patients with atrial fibrillation, also looking at the impact of microbleeds on subsequent intracranial bleeding in patients on anticoagulation. And that would tell us definitively, because at the moment there are some general stroke populations looking at the impact of microbleeds. There's perception that obviously it increased subsequent bleeds. The data in AF cohorts, well, CHROMIS-2 will answer us, properly on the risks associated with this.
So when we have such patients, we have to look at the cause. Is it spontaneous, or has it any mechanical cause that makes a huge difference? We can consider occluders, and we should also look at the brain with appropriate imaging to see what actually and where the bleeding had occurred. And I think that's important for our viewers for their daily practice. Thank you very much for sharing this data with us.